Hello, and thank you for the opportunity to present at this year's conference. My name is Emma Harris, and I'm a Research Fellow from the University of Huddersfield. In my presentation, I'm going to explain how a multidisciplinary team of researchers, software designers, service users, and healthcare professionals work together to co-create a patient decision aid for coronary heart disease treatment options. Firstly, what is the problem? Well, approximately 2.3 million people in the UK are living with coronary heart disease. The main symptom is angina, which is most often experienced as pain and discomfort in the chest. Different treatments are available for people with stable coronary heart disease. Optimal medical therapy or revascularization, such as coronary angioplasty. This is a treatment in which blood vessels in the heart are widened to allow oxygen-rich blood to flow through more easily. International research and UK research from Professor Astin and colleagues have shown that patients underestimate the risks and overestimate the benefits of angioplasty. So many patients with stable angina mistakenly believe that angioplasty is a cure for coronary heart disease, and they will live for longer and are less likely to have a heart attack. But this is incorrect. The main purpose of angioplasty is to relieve angina. This means that many patients are not properly informed before choosing to have angioplasty, which is an ethical and legal requirement for informed consent. One way of improving this is to facilitate shared decision-making. Shared decision-making is a collaborative, two-way interactive process where healthcare professionals work in partnership with their patients to support them to make a decision about their health that is right for them. Decision aids can be used to facilitate this process. As well as providing balanced information about the positive and negative features of each treatment option, decision aids include activities to enable a patient to reflect on their own goals, values and preferences, which can help to understand the potential physical, social and psychological effects of each treatment option. Systematic reviews have shown patient benefits from using decision aids, such as improved understanding and promotion of informed consent. So with this in mind, we therefore decided to develop a digital decision aid for people with stable angina. So besides improving informed consent and decision making, why did we decide to develop a decision aid? Well, let's think about the markers of quality, and the Institute of Medicine identified 6 domains of care quality. Patient-centred care is one of these domains. So you can see on the diagram some of the activities that we do to make healthcare patient-centred. Giving patients health-related information and involving them and their families in their care are key activities. So this new decision aid is a tool that can be used to support all of these activities and therefore potentially improve care quality for people with stable angina. To develop the decision aid, we followed the International Patient Decision Aid Standards framework to ensure robust methodology and also ensure that end users were central in the design process. In the first step, a multidisciplinary steering group was convened to discuss the scope of the decision aid. Discussions informed the initial draft of the wireframe of the decision aid, which showed the potential layout of the digital interface and the main sections. The second step involved reviewing the clinical guidelines for the management of stable angina to ensure the clinical content of the decision aid was current and accurate. To ensure the decision aid aligned with end user requirements, we conducted 3 co-design workshops, 2 of which were with cardiologists and nurses from 2 NHS trusts, and the third was with service users who were recruited from local heart charities and had previously had an angiogram or had received coronary angioplasty treatment. The workshops were facilitated by 2 researchers and field notes recorded by 2 steering group members. The purpose of the workshops were to explore end users' preferences for content, their information and decision support needs, and how the decision aid could potentially fit within the current clinical setting. And I'll provide further details on the workshops in the next slide. Feedback from the workshops were used to develop the first digital prototype of the decision aid, which underwent several iterations following discussions within the steering group. Usability testing of the prototype was completed in the 4th stage, alpha testing. 16 participants were recruited from 2 NHS trusts in Northern England and included 9 cardiologists and nurses and 7 patients who had received coronary angioplasty treatment within the previous 18 months. Using a cognitive interview approach, participants were observed using the digital prototype, and questions were asked by the researcher about the acceptability, comprehensibility, and usability of the decision aid. An acceptability questionnaire was also completed. Interviews were audio recorded, transcribed and analysed using content analysis. So in the workshops we presented our initial ideas for Connect, the digital coronary angioplasty decision tool. The workshops were approximately 2 to 3 hours in duration and involved focus group style discussions and group activities. For example, in the service user workshop, we showed different ways of presenting risks and benefits of treatment options. Participants ranked the designs in order of preference. There was a mixed response. Some people liked the graphical representation of statistical risks, whereas others preferred text. Therefore, we used both styles in the decision aid. Another activity involved asking participants to rank the Connect logo designs in order of preference. A couple of participants designed their own, one of which was turned into Connect's final logo. Now to the alpha testing results. Firstly, the acceptability of Connect. This refers to the ways in which Connect could add value to patients, healthcare professionals and health services. The acceptability questionnaire results were positive, with all items scoring a median of at least 4 out of 5. Content analysis of the cognitive interviews identified that Connect has a potential to facilitate shared decision-making by empowering patients and giving them a voice when making their treatment decision. Participants thought that Connect could improve consent processes, for example by increasing awareness of the key principles of consent, such as making a decision without pressure from others. Also, there were several suggestions of how Connect could increase patient safety, such as by potentially preventing unwanted procedures. The second theme from the content analysis was comprehensibility, which refers to the degree to which the content of Connect was understandable. Most participants felt that the terminology was easy to understand, with only minor suggestions for changes. Several participants expressed concerns about internet access and the use of digital devices, which might act as a barrier to using Connect, especially by older people. The use of graphics to present risk statistics was positively received and aided understanding of percentages for most participants. Only minor suggestions were made about the colour and layout. And finally, to usability. This refers to how Connect was navigated and completed. It was clear from the observations that some modifications are required to help users navigate the decision aid. Participants gave several suggestions to ease navigation, such as providing a home or main menu button. Only a few minor technical issues were experienced during the interviews. All participants liked the personalisation element of Connect and suggested that this could be enhanced further. More pictures and videos are required to help user engagement and increase accessibility. So to summarise, a digital coronary angioplasty decision tool for patients with stable angina was developed following a systematic and robust process that adhere to the International Patient Decision Aid Standards. In total, Connect has been co-created alongside 43 service users and healthcare professionals. Both participatory and user-centred design methods were used to ensure that Connect is usable and aligns with end users' needs. Connect has the potential to improve shared decision-making and informed consent processes. And our next steps are to produce the next version of Connect based on alpha testing results. And then we plan to implement and evaluate Connect in clinical settings. Thank you all for listening. I'd like to thank and acknowledge the whole team of people that have been involved in this project and led by Professor Felicity Astin. Also, thank you to our collaborators from the University of Huddersfield, NIHR Devices for Dignity, the Calderdale and Huddersfield NHS Foundation Trust, the Mid Yorkshire Hospitals NHS Trust, and our funders, GrowMed Tech. If you have any questions, please feel free to write these in the comments below the video, and we will do our best to respond to each one. Thank you and take care.